Welcome back to the deep dive. Today we're tackling a really core topic in anesthesia, central neuraxial blockade, CNB.
Yeah, CNB, spinal, epidural, caudal, all of it.
Exactly. We're aiming for more than just a surface look here. This is about getting to that elite professional understanding, really digging into how and why these high-stakes techniques work.
Right. This isn't just definitions. Our mission today is, well, mastery. We need to get deep into the anatomy, like visualize every layer the needle passes through.
Understand the physiology behind why a block works differently on different nerves.
Precisely. And critically, the risk assessment. When is it safe?
Right.
How do we make it safe? We need to internalize why things like porosity matter, why blood pressure drops, and why every step of preparation is absolutely vital.
It's amazing stuff. And to think, it all kicked off, what, back in 1898?
Augustus, Bier, and Théodore, using cocaine, of all things.
Right. Directly into the subarachnoid space. Got about an hour of anesthesia out of it. Pretty basic compared to now, but wow, what a starting point. It proved you could target that space around the cord.
It absolutely did. It established the whole principle. Okay, so foundational knowledge. If you're going to place a needle accurately near the spinal cord, you absolutely have to have this anatomical map in your head. Let's start with the bones, the vertebral column.
The scaffolding, basically. 33 vertebrae running from the skull down to the coccyx.
And most of them, 24, are movable, right? Thanks to the discs and the joints connecting them.
Yeah, and each individual vertebra, I always picture it like a strong pillar at the front, the body, and then this protective arch at the back.
Good way to think of it. That solid anterior body takes the weight. Then the arch starts with the two pedicles going sort of back and sideways.
Posterior laterally. Then the two laminae complete it, coming back towards the middle.
Posterior medially, yeah.
Yeah.
And that forms the vertebral foramen, that oval or triangular hole that the spinal cord runs through. Protection central.
And sticking off that arch are the processes. Transverse ones out to the sides for muscle attachment.
And the spinous process. That's the one you can actually feel down the back, projecting backwards and usually a bit downwards.
That downward angle is important, isn't it? Especially higher up. Adds protection by overlapping.
It does. And it also affects how easy it is to get a needle in, which we'll get to. But first, the exits for the nerves. The intervertebral foramina.
Formed by little notches on the vertebrae above and below, and crucially, those facet joints, the zygapophyseal joints.
Right. And those facet joints themselves have nerve supply from the spinal nerves passing right by them. So, inflammation or arthritis there, that can directly cause nerve pain. It all connects.
Okay, so regional differences. You mentioned that angle of the spinous processes.
Yeah, hugely important clinically. In the cervical and thoracic spine, those spinous processes angle down quite sharply. They overlap like shingles on a roof.
Makes it super protective for the cord.
But really tricky for needle access. The space between them is minimal. Very challenging, higher risk up there.
But then you get down to the lumbar region.
And it's different. The vertebrae are bigger, chunkier, and the spinous processes shorter, broader, and they point almost straight back. Much less overlap.
So bigger gaps between them.
Exactly. The sources call them relatively large gaps, bridged by ligaments. That's why the lumbar spine, especially below L2, where the cord typically ends, is the go-to spot. It's just anatomically easier to access the spaces we need.
Yeah.
The easiest access point, like you said.
Makes sense. And then even further down, the sacrum and costiox.
Right. The sacrum is 5 vertebrae fused into one big triangular bone. But there's a key feature there for us. The sacral hiatus.
That's the gap at the bottom where the last vertebra's lamina didn't fully form.
You got it. And it's guarded by little bony bumps called the sacral cornua. Those are our landmarks for caudal anesthesia. Palpable, especially in kids, but usually in adults too, before the coccygus fuses completely, which happens somewhere between 25 and 30 usually.
Okay, bones mapped. Now, the ligaments, the stuff the needle actually goes through, this is the tactile part, right? The anesthetist's roadmap.
Totally. First up, usually the toughest superficial one is the supraspinous ligament. It's like a strong cord running right along the tips of those spinous processes.
And it's not just one simple band.
No, it's described as having 3 layers, actually. Superficial, middle, inner, connecting different numbers of processes. So it's a complex fibrous structure even before you get deeper.
And then beneath that, or maybe blending with it?
The inner spinous ligaments. Thinner bands running between adjacent spinous processes. But here's the thing. They can be pretty thin, sometimes even absent, especially in the cervical and lumbar areas where we're often working.
So they don't always provide that much resistance.
Not always, which makes the next layer even more important, the ligamenta flava. the yellow ligaments.
The key ones. Why yellow?
High elastic tissue content makes them yellowish, and they're strong. Paired ligaments that join the arches of adjacent vertebrae. They form the posterior wall of the vertebral canal.
And they're thickest right in the midline.
Exactly. At L2, L3, they can be like 3 to 5 millimeters thick. This is where you really feel that increase in resistance as the needle goes through.
Wrong.
And then
The pop.
the pop. That sudden loss of resistance as the needle tip breaks through the ligamentum flavum and enters the epidural space. That feeling is absolutely critical. It tells you you've arrived. Miss it, and you might be too deep or off to the side.
Okay, ligaments navigated. Let's talk targets. The meninges and the spaces they create. Inside the bony canal, shielding the cord.
3 layers.
Yeah.
Outside in. Duramater first. Thick, tough, protective. Like parchment paper almost.
Then the arachnoid mater.
Yep. Thin, delicate, kind of web-like, hence the name.
And finally, right on the cord itself.
Pia mater. Very thin, intimately attached to the surface of the spinal cord and brain.
So for spinal anesthesia essay, where are we aiming?
We're aiming for the subarachnoid space. That's the space between the arachnoid mater and the pia mater.
And it's filled with...
Cerebrospinal fluid. CSF. This space connects up to the ventricles in the brain. The CSF is constantly being made about 500 millimoles a day, and it circulates, acting as a cushion.
And that's where the local anesthetic goes for a spinal block, directly into the fluid bathing the nerve roots.
Precisely. Now, for epidural anesthesia, EA, the target is different. It's the epidural space.
Epi meaning outside the dura, so it's outside that tough dural sac, but still inside the bony vertebral canal.
Exactly. It's technically a potential space, running from the skull base down to the sacrum, typically only about 5 millimeters wide in the lumbar region.
But it's not just empty space, right? There's stuff in there.
Oh, yeah. It's got veins, the epidural venous plexus. These are valveless, more prominent on the sides, and they get really engorged in pregnancy or obesity. Big risk for accidental IV injection there.
What else?
Fat. Lots of epidural fat acting as padding. Lymphatics. And importantly, the nerve roots exiting the dural sac pass through this space on their way out.
And the structure isn't uniform. I remember reading it's described as discontinuous, metameric.
Yeah, that's a critical point. Forget picturing a nice smooth tube. It's more like a series of compartments, segmented, with these fat-filled tripodial pads, as one source puts it. It narrows and widens.
Why does that complex structure matter so much?
It completely dictates how the epidural anesthetic spreads. It doesn't just diffuse evenly. It has to flow, bulk flow, around these fatty pads and through narrowings, and that flow often isn't perfectly circular.
Ah, so that's why epidural blocks can sometimes be patchy. Or only numb one side. The drug gets stuck behind a fat pad or can't squeeze through a narrow bit.
That's the anatomical explanation, yes. Leads to segmental or incomplete blocks sometimes. It's inherent to the space.
And the depth to get there, it varies a lot.
Hugely. Averages maybe 5 centimeters in the lumbar spine, but the range is like 2.5 centimeters to 8 centimeters or even more. Depends massively on body habitus.
Which is a great argument for using ultrasound beforehand, right? To estimate depth.
Absolutely. Especially in challenging patients. But anatomically, the space is generally deepest right in the midline. In the mid-lumbar region, maybe 5 to 6 millimeters deep there, gives you a slightly bigger target, #tag 2, the central neuraxis and mapping anesthesia.
Okay, let's zoom in on the spinal cord itself now. How far down does it actually run?
Typically in adults, it extends from the medulla oblongata at the base of the brain down to about the level of the L2 vertebra. Sometimes L1, occasionally L3, but L2 is the most common endpoint.
L2, that's a landmark we absolutely have to remember.
Crucial, because in infants, it extends lower, maybe L3. But in adults, ending at L2 means if we place our needles below L2, usually L3, L4, or L4, L5 interspace, we're aiming into the CSF, bathing the bundle of nerve roots after the cord is ended.
The cauda equina, the horse's tail.
Exactly. The cord tapers down into the conus medullaris, and then those nerve rootlets for L1 down to S5 continue down within the dural sac as the cauda equina before they exit. Aiming below L2 minimizes the risk of hitting the actual spinal cord tissue with the needle.
Makes sense. The cord also has enlargements, right? For the limbs.
It does. A cervical enlargement from about C4 to T1 spinal segments, where the nerves forming the brachial plexus for the arms originate.
And a lumbosacral one.
Yep. L2 to S3 spinal segments, forming the lumbar and sacral plexuses for the legs. But here's a key point of potential confusion.
The spinal cord level doesn't match the vertebral bone level?
Right, because the vertebral column grows longer than the spinal cord during development. So, for example, those L2-S3 nerve segments that form the lumbosacral enlargement, The actual nerve cell bodies for those are located much higher up in the cord, typically between the T11 and L1 vertebrae.
Okay, that's important if you're trying to figure out the level of an injury or why a block is behaving a certain way.
Definitely. Now, once we've given the anesthetic, how do we know how high it's spread? That's where dermatomes come in.
A dermatome being the patch of skin supplied by a single spinal nerve root.
Correct. We use standard dermatome maps, knowing, for example, that T4 is roughly the nipple line, T6 the xiphoid process, T10 the belly button, to assess the level of the sensory block.
And how do we test that clinically? Motor function seems pretty straightforward.
Yeah, motor's often easiest. Can the patient lift their legs straight? Can they push their foot down like pressing a gas pedal? If they can't activate those muscles, the motor block is dense at those nerve root levels.
Sensory testing needs a bit more care.
It does. You need something to test sensation, sharp, dull, or cold. Could be a pinwheel, a broken tongue depressor, an alcohol swab, or an ice cube.
And the technique is to test moving upwards.
Yes, test cephalid. Start in an area you know is numb and slowly move upwards, testing in maybe 2 or 3 inch bands, asking the patient to tell you exactly when the sensation changes, when it starts to feel normal or sharp or cold again. That point marks the upper edge of your sensory block. #3. Physiology and mechanisms of action. The drug action.
All right, let's shift gears to physiology and pharmacology. How do these local anesthetics actually work when they get near the nerve roots?
The main site of action is definitely the nerve roots themselves, bathed in CSF for spinal, or diffusing across the dura for epidural. And the core mechanism is blocking sodium channels.
Voltage-gated sodium channels, the ones needed for nerve impulses.
Exactly. By blocking those channels, local anesthetics prevent the nerve cell from depolarizing, so the action potential, the nerve signal, can't start or travel along the nerve fiber.
But it's not an all-or-nothing thing, right? Different nerves get blocked differently.
That's absolutely key. This is the concept of differential susceptibility. Nerve fibers vary a lot in size, whether they're myelinated or not, and what they do. And this massively affects how sensitive they are to local anesthetics.
The classification table, A alpha, A delta, B, C fibers.
Right, and the ones we really need to focus on initially are the B fibers. They're small, lightly myelinated, and they carry the preganglionic autonomic signals, the sympathetic signals.
And they're the most sensitive to the block.
By far. They get blocked much more easily at lower concentrations and faster than other fibers.
Which leads directly to
Differential blockade. You block the sympathetic nerves first and most extensively. Then come the nerves for pain and temperature, the small A delta and C fibers. And last, usually requiring higher concentrations, are the larger A alpha fibers responsible for motor function and touch pressure.
Okay, so the sympathetic block happens first and spreads highest.
Yes, and this is critical for understanding the side effects, because those sympathetic nerves control blood vessel tone and heart rate. Blocking them widely leads to vasodilation and potential bradycardia. The sympathetic block can easily be 6 or more dermatome levels higher than where the patient stops feeling cold or sharp.
6 levels. So if your sensory block is at T10, your sympathetic block could be way up at T4.
Easily. And that explains the profound drop in blood pressure we often see. It's a direct result of this differential blockade hitting the sympathetic chain.
It's also interesting that even when someone feels completely numb, it's not necessarily a total chemical cut of the cord.
No, that's an oversimplification. You can sometimes still record signals like sonosensory evoked potentials getting through to the brain, even if the patient isn't consciously perceiving pain. It's more like the anesthetic is filtering or selectively interrupting the traffic rather than completely severing the connection.
Okay, let's compare spinal versus epidural mechanisms again based on this.
Final anesthesia,
Yeah.
SASRSSA. Drug goes straight into the CSF. Fast onset. Dense block usually. Spread depends heavily on the drug's properties, especially baricity and the CSF itself.
Epidural anesthesia, yeah.
Yeah.
Much slower, more steps involved. Drug has to spread through that complex, fatty epidural space first.
Often by bulk flow, non-circumferentially, remember?
Right, and then it has to diffuse across the duramater, especially at the dural cuffs where nerve roots exit and the dura is thinner, to actually reach the nerve roots in the subarachnoid space.
Exactly. That two-step process, spread, and then diffusion, is why epidurals typically produce a less dense block initially, often more segmental. You usually need more volume or a higher concentration to get a solid surgical block compared to a spinal.
Now let's talk about controlling that spread, especially for spinal. Baricity is huge here.
Absolutely central. First, CSF isn't just water. It has a specific gravity, usually 1.004 to 1.009. It varies a bit with temperature, glucose, protein. Vericity is just comparing the density of our local anesthetic solution to the density of the patient's CSF.
And we can manipulate this?
We can. We make solutions. Isobaric. Density is about the same as CSF, vericity around 1. We might mix the drug with normal saline or even the patient's own CSF. These tend to stay put roughly where you inject them, less affected by gravity. Hyperbaric. Density is greater than CSF, vericity 1.0015, usually made by adding dextrose, like 5% or 8%. These solutions are heavy. They sink. Hypobaric. Density is less than CSF, vericity 0.999, usually made by mixing with sterile water. These solutions are light. They float.
So hyperbaric for a saddle block where you want it low.
Exactly. Patient sits up, the heavy solution sinks down to bathe the sacral nerves. Or hypobaric for prone positioning.
Patient's prone, you inject, the light solution floats up to cover the nerves needed for, say, perianal surgery, while keeping the block from spreading too far cephalid.
Precisely. So the anesthetist controls the spread using the total dose, the injection site, the vericity, and critically patient positioning, especially right after injecting a non-isobaric solution. How long you keep them in that position matters.
And what about making the block last longer?
Drug choice matters. Things like tetracaine and bupivacaine are highly protein-bound, so they stick around longer near the nerves. But the biggest duration booster is adding a vasoconstrictor.
Epinephrine, usually.
Yeah, typically a tiny amount, like 0.1 to 0.2 milliliters of 1.100 epinephrine. It constricts local blood vessels, reducing how quickly the anesthetic gets absorbed away from the nerve roots. Works best with drugs like tetracaine.
And for pain relief without heavy motor block, adjuncts.
Right. Intrathecal opioids are fantastic for this. Small doses like 10 to 25 micrograms of fentanyl or maybe an alpha-2 agonist like clonidine, around 150 micrograms. They work directly on pain receptors in the spinal cord, extending analgesia significantly without adding much, if any, motor block. Great for post-op pain, #TAG-AMB, clinical utility and preoperative considerations. The risk assessment. Okay, clinical utility, where do we actually use CNB? It's incredibly versatile. Lower limb surgery, perineal procedures, lots of abdominal work.
Plus pain management, both acute post-op and chronic pain conditions, and, of course, obstetrics. It's huge in L&D.
Absolutely. And often it's part of a balanced approach, right? Combine regional with maybe light general anesthesia or sedation to get the best of both worlds. Minimize drug doses overall.
And the data showing benefits over general anesthesia alone is pretty strong, isn't it?
It really is. Studies consistently show reductions in things like surgical time, blood loss, infection rates, even hospital stay. Fewer lung and heart complications, less nausea and vomiting.
Plus, better mental clarity afterwards, and that preemptive analgesia stopping pain before it ramps up.
Exactly. And in specific situations, the benefits are even clearer. Like obstetrics epidurals give amazing pain relief for labor without knocking the mother out or significantly depressing the baby.
And if you suddenly need a C-section,
you can just top up the epidural catheter with a stronger solution for surgical anesthesia. QUIP, safe conversion.
Perfect example. Or think about TURP surgery, transurethral resection of the prostate.
Right, you mentioned this. With spinal, the patient's awake.
So they can tell you immediately if they feel bladder fullness or pain, helping prevent bladder perforation. Plus, you can monitor their mental state for early signs of TURP syndrome, that dangerous fluid overload and low sodium state. An awake patient is a crucial monitor there.
And prone positioning, too. Using hypobaric spinal means the patient can stay breathing on their own for, say, rectal surgery, avoiding the hassles and risks of general anesthesia while prone.
Definitely. But before we even think about placing the needle, the pre-op conversation is vital. Building rapport, dealing with the common fears, paralysis, being awake, pain.
All of that. But from a purely procedural standpoint, we have to nail down 3 key questions. 1, is the patient actually okay with this? Will they be comfortable? 2, can they physically hold the position we need them in, sitting, side-lying, whatever, for the whole time it takes? 3, and the big one, do the benefits of doing this regionally outweigh the risks compared to just doing general anesthesia?
Which leads us straight into contraindications, the reasons not to do CNB.
And we usually break these down: absolute, relative, and controversial. Absolute means really don't do it. The risk is just too high.
Top of the list.
Patient refusal, always absolute. Then active coagulopathy or significant bleeding disorder, severe hypovolemia shock, infection right at the injection site, and crucially, increased intracranial pressure, ICP.
Why is high ICP such a no-go?
If you puncture the dura in someone with high ICP, you create a low pool pressure outlet. CSF leaks out, and the pressure gradient can actually cause the brainstem to herniate downwards through the foramen magnum. Catastrophic.
Yikes. Okay, what else is absolute?
Certain heart conditions. specifically severe fixed output states. Think severe aortic stenosis, severe mitral stenosis, hypertrophic cardiomyopathy.
Why are those so dangerous with CNB?
Because these patients need adequate preload,
Yeah.
venous return, and systemic vascular resistance, SVR, to function. Their hearts can't increase output easily. CNB causes sympathetic blockade, which massively drops SVR and venous return.
So their blood pressure tanks and the heart can't compensate.
Exactly. It can lead to sudden, severe hypotension, coronary ischemia, even cardiac arrest. Spinal or epidural is generally considered absolutely contraindicated in these severe cases, though sometimes very carefully titrated epidural opioids might be considered in specific expert hands, but the risk is extremely high.
Okay, moving to the big procedural fear, bleeding, coagulopathy, and anticoagulation. The risk of spinal hematoma, VCH.
Vertebral canal hematoma. It's rare, thankfully maybe 1 in 150,000 spinals, 1 in 200,000 epidurals, but the consequence is often permanent paralysis. So the fear is justified.
And the risk isn't the same for everyone.
No. Risk goes up with age if there are underlying spine problems like stenosis, if a patient has any kind of coagulopathy, if the needle placement is difficult or traumatic, and especially if there's an indwelling epidural catheter left in place while the patient is on significant anticoagulants.
Are there hard cutoffs like platelet counts?
There are some general guides, like maybe avoiding CNB if platelets are below 100,000 or if PT-TAP-TT are more than twice normal. But these are a bit arbitrary and maybe overly cautious, especially just for a single-shot spinal. The real key is adhering to established guidelines.
The ASRA guidelines, American Society of Regional Anesthesia, and SOAP for obstetrics.
Exactly. They publish detailed, evidence-based timing guidelines for virtually every anticoagulant and antiplatelet drug out there. You have to know these.
Like how long to wait after the last dose of heparin or LMWH before you can do the block, or remove a catheter.
Precisely. For example, standard prophylactic heparin. You need to wait 4 to 6 hours after the dose before needling or pulling a catheter. For prophylactic LMWH, like enoxaparin, it's a minimum of 12 hours. For therapeutic doses, it's much longer. These intervals are non-negotiable safety nets.
And it's not just prescription drugs, right?
Good point. We have to ask about herbals, too. Garlic, ginkgo, fish oil. Lots of common supplements can affect platelet function and increase bleeding risk. Needs a thorough history.
What about patients with pre-existing nerve issues, neurologic disease?
That's more in the relative contraindication category, usually. Things like severe scoliosis or previous back surgery make placement technically difficult and can make the anesthetic spread unpredictably. Ultrasound can be really helpful there to map things out first.
And peripheral neuropathies, like diabetic neuropathy.
Those nerves are already potentially compromised. They might be more susceptible to injury from the needle itself, from local anesthetic toxicity, or even from ischemia caused by epinephrine in the solution. There is also the worry about the double crush phenomenon.
Where an existing nerve problem is made worse by a second insult at the block site.
Exactly. Like existing nerve root compression in the lumbar spine gets acutely worse after the block is done near it. Needs careful consideration and documentation.
And demyelinating diseases, MS Guillain-Barré.
Also relative contraindications. The concern is that these already damaged nerves might be extra sensitive to local anesthetics, potentially worsening the condition. Again, thorough pre- and post-block neurological exam and documentation are absolutely essential if you proceed. #TAG-V. Managing physiologic alterations and complications.
Okay, let's talk about what CNB actually does to the body, system by system, and the complications that can arise. CNS effects first.
Well, the most common CNS effect is just somnolence, drowsiness. It's usually because the block reduces the amount of sensory information going up to the brainstem's reticular activating system. Less input, less arousal.
But you need to be careful if the patient is already sleepy from other drugs.
Absolutely. If they've had opioids or alcohol or other sedatives, adding CNB on top can really potentiate the sedation and increase the risk of respiratory depression. Needs careful monitoring.
The big one, though, is the cardiovascular system. We touched on this with differential block.
Right. Sympathetic blockade is the main player. Blocking sympathetic nerves causes arteries and veins to dilate. Arterial dilation drops systemic vascular resistance. Venous dilation causes blood to pool in the legs, reducing venous return to the heart. Both lead directly to hypotension.
And if the block goes high enough?
If it reaches T1, T4, it blocks the cardiac accelerator nerves. That causes bradycardia, a slow heart rate, which makes the hypotension even worse because the heart can't compensate by beating faster.
And then there's that reflex, the basal gerish.
Ah, yes, the BJR. It's a paradoxical really dangerous reflex. It happens when venous return drops so much that the ventricles are almost empty, but trying to contract forcefully.
The underfilled heart contracts rapidly.
Right. And this stimulates specific receptors, 5-HT3 receptors, in the heart wall. That triggers a massive vagal nerve outflow,
Leading to sudden, profound.
bradycardia, more hypotension, and even more vasodilation. It's a vicious cycle downwards into cardiovascular collapse if you don't recognize and treat it instantly.
So managing hypotension is priority number one. How do we define it usually?
Generally, a drop of more than 20% from the patient's baseline blood pressure or any pressure low enough to cause symptoms, and you treat it aggressively.
Fluids first. Preload versus call-load.
Fluids are key. The evidence seems to favor co-loading, giving a fluid bolus, like 15-20 mg of crystalloid, at the same time as you're doing the block, or right after, rather than preloading heavily beforehand, gets the fluid in when the vasodilation is actually happening.
And drugs. Ephedrine versus phenelphine.
Depends on the heart rate. If the patient is hypotensive and bradycardic, ephedrine is usually first choice. It's a mixed alpha and beta agonist, so it increases heart rate, beta, and vasoconstricts alpha. Give maybe 5-10 milligram IV pushes.
But if the heart rate is normal or even high,
Then phenylotion is better. It's a pure alpha agonist. It strongly vasoconstricts to bring the pressure up, but without stimulating the heart rate further. Usually give 50-100 milligram IV pushes.
and for severe bradycardia or if you suspect BJR,
Atropine, promptly. And maybe even epinephrine if things are deteriorating rapidly. Interestingly, the anti-nausea drug ondansetron, which blocks those 5-HT3 receptors involved in BJR, has actually been shown to reduce the incidence of spinal-induced hypotension, a nice side benefit.
what about breathing, respiratory effects?
Direct paralysis of the phrenic nerve, which controls the diaphragm, is rare unless the block goes extremely high up into the cervical levels. But CNB does affect the accessory muscles of respiration, the intercostals and abdominal muscles.
So patients might feel like they can't take a deep breath.
Exactly. They often report feeling short of breath or dismaic, even if their oxygen saturation is fine. It's often the loss of sensation of their chest wall moving. But it means you have to be extra cautious adding sedatives that could depress their real respiratory drive.
And the gut, GI system.
Sympathetic block leads to unopposed parasympathetic activity, mostly via the vagus nerve. The parasympathetic system stimulates the gut.
So constricted bowel, more paracelsus.
Yep, small contracted bowel, active peristalsis, maybe increased secretions. Surgeons often like this, gives them better operating conditions, but it's also why nausea and vomiting are fairly common, maybe up to 20%. It can be from the gut hypermotility itself or secondary to the hypotension.
Okay, let's tackle the complication everyone asks about. Postdural puncture headache. PDPH. What causes it?
Simple mechanics, really. The needle makes a hole in the dura. CSF leaks out faster than it can be replaced. This reduces the fluid cushion the brain and brainstem are floating in.
So when the patient sits or stands up,
Gravity causes the brain to sag slightly, stretching the pain-sensitive meninges, especially the tentorium cerebelli. That stretch causes the characteristic headache. Cerebral vasodilation might play a role too, trying to compensate.
and the headache is worse standing, better lying down.
That's the hallmark. Positional headache. Usually bilateral, often frontal or occipital, maybe radiating to the neck. Can also have nausea, vomiting, sensitivity to light, sometimes even weird hearing changes like tinnitus or muffled hearing.
Incidence varies wildly though, right? Depends mostly on the needle.
Hugely. Needle size and type are the biggest factors. Large bore needles, and especially cutting needles like the Quincke that slice a bigger hole, have much higher PDPH rates. The sources quote like 5.2% for a 26G Quincke. Compared to non-cutting, pencil point needles like the Whitaker or Sprott, a 25G Whitaker has an incidence closer to 1.2%, much lower. Other risk factors are being female, young, under 40, pregnant, and having multiple dural punctures.
How do we treat it?
Start conservative, lie flat, push oral fluids, caffeine helps constrict cerebral blood vessels, sometimes simple analgesics, bed rest.
But if that doesn't work or it's severe,
Then the definitive treatment is the epidural blood patch, or EBP.
injecting the patient's own blood into the epidural space.
It's exactly. Draw about 15-20 milliliters of the patient's venous blood sterilely, and then inject it slowly into the epidural space at or near the level of the dural puncture. The idea is the blood clots, plugs a hole in the dura, and possibly provides a bit of volume to cushion the brain again.
And it works well.
Very well. Success rates are over 90%, often provides dramatic, almost instant relief. There's also a non-invasive option sometimes tried, the sphenopalatine ganglion block, SPGB, done via the nose.
What about TNS, transient neurologic syndrome?
Yeah, TNS. This is Pain, burning, aching, cramping, usually starting in the buttocks and radiating down the legs. Comes on hours to a day after the spinal wears off, lasts a few days to maybe a week or so, then resolves completely on its own.
And it's strongly linked to one drug in particular.
Overwhelmingly linked to spinal lidocaine. Much less common with other agents like bupivacaine or ropivacaine. Mechanism isn't totally clear, maybe some direct nerve irritation. Treatment is just support. NSAIDs usually help.
Okay, a really scary one, unexpected cardiac arrest. How common is that?
It's not vanishingly rare. Estimates are around 7 per 10,000 spinals, maybe 1 per 10,000 epidurals. Can happen relatively quickly, like 20 to 60 minutes after the block is placed.
And the cause is usually?
Almost always related back to that profound sympathetic blockade causing drastically reduced preload, potentially triggering reflexes like the BJR, or uncovering underlying issues. It's often preceded by worsening bradycardia.
So the key is prevention and rapid response.
Absolutely. Vigilant monitoring, aggressive treatment of hypotension, and especially bradycardia. Don't let bradycardia linger. Use atropine ephedrine early. If arrest occurs, standard ACLS, but with a strong emphasis on epinephrine early and addressing the likely preload deficit.
Lastly, infection and direct nerve injury.
Infection risk is very low with proper sterile technique, maybe 0.04% or less. But epidural abscess or meningitis are devastating. Risk factors are things like diabetes, immunocompromise, steroids, existing infection elsewhere. Meticulous sterile prep is vital. Chloroprep is often recommended.
Common bugs.
Staph aureus for epidural abscesses, strep species for meningitis, often originating from skin or maybe the operator's own flora.
And direct nerve injury from the needle or catheter.
Extremely rare, less than 1 in 10,000 probably. Causes could be direct trauma, injecting drug into a nerve, neurotoxicity of the drug itself, or compression from a hematoma or abscess.
And if a patient develops a new neurological deficit after CNB,
That's a neurological emergency. Needs urgent investigation, usually imaging like MRI, to rule out hematoma or abscess. If there's a compressive lesion, getting the patient to surgery within about 8 hours offers the best chance of recovery and minimizing permanent damage. Time is critical. #TAG6, specialized techniques, epidural, CSE, and caudal. Okay, let's zoom in on the specific techniques, starting with standard epidural anesthesia, EA. The needles are different, right?
yeah, bigger gauge usually, 16 or 18, longer, and the tip design is special.
Right. The 2A needle is classic, with that gentle 30-degree curve and blunt bevel. The Husted is similar, maybe a 15-degree curve. The idea is the curve helps the needle deflect off the dura rather than puncture it easily. There are straight needles too, like the Crawford, sometimes used for tricky angles.
And finding the space. The main technique is loss of resistance, LOR.
By far the most common. You advance the needle slowly, applying constant pressure on the plunger of a syringe attached to it. The syringe contains either air or saline.
And when you pop through the ligamentum flavum into the epidural space,
The resistance disappears, the plunger suddenly gives way easily. That's your confirmation. Saline is often preferred over air.
why saline over air?
Some studies suggest air can cause problems, maybe incomplete blocks if air bubbles get trapped, or theoretically a risk of air embolism if injected intravascularly, though that's very rare. Saline lore is generally considered smoother and potentially safer. There's also the older hanging drop technique, but that's not really for novices.
Once you find the space, you thread the catheter. How far in?
Good question. Evidence suggests threading it about 3 to 5 centimeters beyond the needle tip is optimal. Too shallow, it might slip out. Too deep, it might go out of foramen or coil up.
And the absolute never rule.
Never pull the catheter back through the needle. The sharp bevel of the epidural needle can easily shear off the tip of the plastic catheter, leaving a piece behind in the patient. If you need to reposition, you pull the needle and catheter out together and start over.
Safety first. Then comes the test dose. Why is this so important?
It's a critical safety check with 2 purposes. We usually use 3 milliliter of 1.5% lidocaine with 1,200,000 epinephrine.
Lidocaine checks for.
Intrathecal injection. If that 3 millivol accidentally went into the CSF, the patient will get numb legs and motor block within about 3 minutes, a sign of an unintentional spinal.
And the epinephrine checks for?
Intravascular injection. If the needle or catheter tip is in an epidural vein, that 15 micrograms of epinephrine will cause a sudden transient jump in heart rate by at least 20% and blood pressure within about 30 seconds. Maybe some palpitations or tinnitus too. Tells you you're in a vessel.
So test dose negative, then you dose the epidural. How do you decide how much?
It's about controlling 2 things: density and spread. Concentration of the local anesthetic determines the density or depth of the block. Volume determines the spread or how many segments get covered.
And it takes more volume per segment in the lumbar spine.
Generally, yes. Maybe 1.25 to 1.5 millirich per dermatome segment you want to cover in the lumbar region. In the tighter thoracic or cervical epidural space, it's less, maybe zero point 0.7 to 1 millirich per segment.
And you give it slowly?
Always, incrementally. Give maybe 3 to 5 millimol, wait a few minutes, assess the effect and the patient's vital signs, then give another increment. Build the block gradually and safely.
What about adding opioids to the epidural for pain?
Very common, especially for post-op pain. But remember, they have to cross the dura to work and they get absorbed by epidural fat. So you need much higher doses than for intrathecal opioids, roughly 10 times higher.
Different opioids have different profiles.
Definitely. Lipophilic ones like fentanyl or sufentanil get into the CSF quickly, fast onset, but shorter duration because they also clear quickly. Hydrophilic ones like morphine take longer to cross the dura, slow onset, but they stick around in the CSF for a long time, giving prolonged analgesia.
And that extended-release morphine, Depo-Dur.
Right. It uses a special lipid-based delivery system, Depo-Foam, to release morphine slowly over up to 48 hours. Great for prolonged post-op pain, but the key warning is you cannot mix it with local anesthetics in the epidural. It disrupts the formulation.
Ultrasound again. Its role in epidurals.
Increasingly huge, especially for patients where landmarks are hard to feel, obesity, scoliosis, prior surgery. Ultrasound lets you see the bony landmarks, identify the correct interspace, measure the depth to the ligamentum flavum and epidural space before you stick the needle in.
Reduces failed blocks and accidental dural punctures.
Significantly. It improves success rates and safety, especially in difficult cases. It's becoming standard of care in many places.
Okay, let's move to combined spinal epidural, CSE. Best of both worlds.
That's the idea. You get the rapid onset and reliable density of a spinal block for the start of surgery, plus you have an epidural catheter in place for extending the block if needed, or for post-op pain control.
How do you actually do it? 2 separate pokes.
That's one way, the two-level technique. Do an epidural at one level, then a spinal at an adjacent level, or more commonly now, the single-level needle-through-needle technique.
Where you put the spinal needle through the epidural needle.
Exactly. Find the epidural space with the Tuohy needle first, then pass a long, thin spinal needle through the Tuohy, puncture the dura, inject the spinal dose, pull the spinal needle out, and then thread the epidural catheter through the Tuohy.
Seems technically tricky.
It takes practice, and there's a newer variation called dural puncture epidural, or DPE.
Where you poke the dura but don't inject spinal meds.
Right. You make a small hole with the spinal needle, then remove it and place the epidural catheter. The theory is that small hole allows the epidurally administered drug to leak into the CSF more easily, giving faster onset and maybe a better quality epidural block than standard EA. Early data looks promising.
Any unique issues with CSE? Needle bits.
There's concern about tiny metal fragments being shaved off as the spinal needle passes through the epidural needle bevel. Microscopic studies found them, but larger clinical studies haven't shown any increased risk of problems like meningitis or anything serious.
What about the block getting unexpectedly high?
That can happen, especially with the needle-through-needle CSE. If you inject the epidural dose soon after the spinal, the volume added to the epidural space might squeeze the dural sac, the volume effect theory, pushing the spinal anesthetic higher than expected. Or maybe some epidural drug leaks through the dural puncture hole, the leak theory. Needs careful dosing and monitoring. Failure rates for CSE are also noted, varying quite a bit in studies.
Okay, last technique. Caudal anesthesia, going in from the bottom.
Yep. It's essentially an epidural block performed via the sacral hiatus, that gap at the bottom of the sacrum.
Geez, mainly.
Very common in pediatrics for surgeries below the umbilicus hernia repairs, circumcisions, lower limb stuff. Also used sometimes in adults for anorectal or chronic pain procedures. But it's less predictable in adults because the sacral anatomy varies more after fusion.
How's it done? Patient position.
Usually prone or lateral. You feel for those 2 bony bumps, the sacral cornua on either side of the hiatus. Insert the needle right in the middle, angled steeply at first to pierce the membrane covering the hiatus, then flatten the angle and advance the needle just a centimeter or 2 into the sacral canal itself. Don't go too far up, ideally no further than the S2 level to avoid the dural sac.
Dosing in kids is weight-based?
Yes, typically 0.5 to 1 millimol per kilogram of dilute local anesthetic, like 0.2% ropivacaine. Max dose around 2.5 millikilogram total. Adding clonidine as an adjunct gives great long-lasting pain relief without opioid side effects like respiratory depression, which is a big plus in kids.
Complications specific to caudal.
Intravascular injection is a risk because there are large veins in the sacral epidural space. Careful aspiration is key. Dural puncture is possible, especially in infants where the dural sac ends lower, maybe down at S4. And as mentioned, failure rates in adults can be significant, 10–15%, just due to anatomical difficulty finding the space correctly. Hashtag tag outro Adorno.
Wow. Okay, that was a truly deep dive into CNB. We've gone from the macroanatomy of the vertebrae all the way down to the microanatomy of, those fat pads in the epidural space and how they affect spread. It really highlights the elegance and the precision required.
It absolutely does.
Mm.
Understanding that anatomy, the physics of baricity, the physiology of why blood pressure drops, why different nerves are blocked at different rates,
Yeah.
it's all interconnected. And then layering on the risk management, the ASRA guidelines, recognizing PDPH, managing complications like BJR or potential hematoma, it requires constant vigilance and deep knowledge. It's not just about technique, it's about understanding the why.
And it's a field that's constantly changing too, isn't it? With ultrasound becoming standard, new drug formulations, refining techniques like CSE.
Exactly. Regional anesthesia is incredibly dynamic. Which brings us to a final thought, maybe a challenge for you listening.
Okay.
We talked about the absolute contraindications for CNB in patients with severe heart conditions like aortic stenosis or severe hypovolemia because of the risk of hemodynamic collapse. But consider the advancements.
Ultrasound guidance for precision, maybe hypobaric techniques for controlled spread.
Right. Combine that with potentially ultra-low dose spinal components in a CSE, relying more on targeted epidural opioids for analgesia. Could these modern tools and strategies allow us to revisit those absolute contraindications in select cases? Could we tailor a CNB technique that provides the benefits without unacceptable hemodynamic risk, even in these challenging patients?
Shifting that risk-benefit analysis with new technology and pharmacology.
It's something that requires careful thought, ongoing research, and as the famous anesthetist Alice McGaugh said back in 1899, ultimately relies on the hard school of practical experience. But it's worth pondering how far we can push the boundaries safely.
A fascinating and critical question to end on. Thank you for joining us for this deep dive.